that is the biomechanics, trauma fixation, and we'll chat a little about general principles, and then the biomechanics of plates, nails, and external fixation, sators. Now, these are very basic topic, but it's very relevant, not only for your exam, for those preparing for intermediates, but also in real life, because a lot of the how can I say, errors made in trauma fixation in cases we see where there's failure can be contributed to poor understanding of biomechanics. So these are the learning objectives just overall, and I'm going to start by showing this patient, and I want to show you guys how this fracture was fixed, and then I want you to think through the lecture and what you think the outcome is going to be and why. So that's the initial fracture. As you can see, a slightly complex mid-shaft humerus fracture with a butterfly segment, small area of comminution, and this is the post-op X-ray. So have a look, try and think in your mind what was the aim of the treatment here. Did they achieve that so that they execute their plan, and what do you think the outcome will be of this case? Okay, so firstly, to just go back into basic is what do we require for fracture healing? Well, we need an osteoconductive scaffold. In orthopedics, that is 2 bone ends. We need the optimal mechanical environment, so that is just the right amount of strain. If we fix something with absolute stability and no gap, we get primary bone healing. If we fix it with absolute stability but a gap, we get a non-union. If we achieve just the right amount of micro movement with bridge plating or nailing technique, we'll get healing through secondary bone healing. But if we have too much movement, we get non-union again. We also need the appropriate local biological environment in the form of osteogenic cells, and also the ideal systemic biological environment. And these are all the host factors, growth factors, and so forth for healing. So primary or direct bone healing is not really bone healing. This is just bone going through its normal process of remodeling, and you get healing without callus. That we all know. We're not going to spend too much time on that. Secondary bone healing is healing as we see in nature, a non-operative management. It's healing for an inflammatory response with distinct stages of healing and callus formation. Now, how do we achieve the optimal mechanical environment? Well, there's not a lot that we can influence really. We can only really influence the stability and the gap with our fixation. I've just highlighted this article, which I think is a must read for everyone. It's not a scientific study, it's just more of an editorial, basically putting together all the different theories of bone healing and how it results in non-union. And it's a must read for everyone. For those who haven't seen it, to definitely get this article and read it. So important concept to understand is the concept of strain. Now, strain is the deformation of tissue in a gap. Strain is calculated as the change in length over a gap. Steve Dillon sort of coined this theory. So basically, it is calculated as the change in length of a fracture divided by the gap or the width of the fracture, and it's expressed as a percentage. Now, for direct bone healing, we need less than 2% strain, so between 0 and 2. For callus formation, we need between 2 and 10%, and if we have more than 10% strain, we just have basically fibrous tissue formation, and it won't progress to healing. So as you can see here, change in length over length. Very important to understand, for the same amount of movement, A fracture with a smaller gap would have a higher strain environment. So this is the principle overall for simple fractures. You should avoid bridge plating because it is very difficult to get the strain low enough for healing to take place. So in general, simple fractures is treated with anatomical reduction and rigid fixation for primary bone healing, and complex fractures is treated for with bridge plating. Okay, so small gap compression, absolute stability, healing without any callus. Same gap but no compression. So there's a small gap, basically a bridge plate for a small gap. Any movement here will be distributed over a very narrow zone, and it will give a high strain environment and lead to poor healing. So bridge plating of a simple fracture is a non-union machine. For a comminuted fracture, the same bridge plate will have a lower strain because basically if you look at how strain is calculated, your denominator, which is the gap, is bigger. So dividing by something that's bigger is going to have a lower strain. Is everyone happy with that and understands that concept?
Yes, Prof.
Okay, great.
Yes,
I think I should swap some of you guys with our current registrars who seems to struggle with this concept from time to time. Don't tell them I said that. Okay, so this is another so like indirect how you should address the fracture is to ask yourself, for this specific fracture, what is important? Is an anatomical reduction important, as in for an intra-articular fracture, or is alignment important? So if anatomy is crucial, then you aim for anatomical reduction and rigid fixation with absolute stability and direct bone healing, like for intra-articular or periarticular fractures. Where alignment is crucial, just for like the diaphyseal fractures. So in other words, anatomical reduction is less important. You mainly want to align the joint above and the joint below into its normal anatomical relation. Then you're going to aim for either bridge plating or intramedullary nailing. So to summarize, where anatomy is crucial, absolute stability, rigid fixation, and for primary bone healing, and in when you just want to align fragments, bridge plating or nailing, and then it's important to stay away from the fracture zone. Okay, so to go on to plating, okay, we're going to discuss the different functions of a plate. We're going to look at some of the features of a plate to enable those functions, how you can use a plate for absolute and relative stability, and chat a bit about the indications for locking plate screws. Okay, so plate function, different plate functions are summarized here. So you can use a plate as a compression plate. You can use a plate as a protection plate or a neutralization plate. You can use a plate for a buttress or anti-glide plate, and you can use a plate for a tension band plate. Those all usually gives you absolute stability of indirect healing. You can also use a plate for bridge plating, which would give relative stability. So I'm going to ask one of you guys here. Let me look and pick at a name. Devang, do you want to tell me what plate is this that we're looking at?
Yes, Prof. This plate looks like well, yes, it looks like a distal humerus anatomical plate. Yeah.
Okay, distal humerus anatomical plate. Great. So I'm going to ask you, can it be a bridge plate?
Can it be a bridge plate?
Okay, can it be a compression plate?
It looks like there is that option of the dynamic.
Can it be a locking plate?
Yes, it can.
Okay, good. So it's important to notice that we should separate plate function and plate design. So the same plate can be used in different modes. So basically, plate design doesn't dictate the function. The function of a plate is dictated by the way you apply the hole. So the same plates can be used as a protection plate if you've already used interfragmentary screws. Can be used as a compression plate if you just utilize the dynamic compression holes. It can be used as a bridge plate with or without lock screws, and it, so basically that depends on how you apply it. And that's a common error that people look at a plate and say it's one or the other. So if we look at plate design, we said is a biological cost of plating. With compression plating, the area underneath the plate, the periosteal blood supply is often affected. And this, if you look at the top here, the very first generation compression plates had a large under surface contact area with the bone. And so that's what a DCP looked like. So if some of you guys refer to the sort of plates we use nowadays as a DCP, that's wrong. I don't think any of you have ever seen a proper DCP. Has anyone ever used a proper DCP that looks like this underneath?
The some of the plates from flip now, I can't remember the company that's still at Victoria is still the old-fashioned.
Okay, Roth was one of them. Okay, then sort of what a lot of us refer to as DCPs is this what's called the LC-DCP, which is a limited contact dynamic compression plate from Synthes, where there's cutouts underneath to decrease the contact area with the bone. PC Fix was around for a very short time with Synthes, where they had much bigger contact, and you just had these much less contact, bigger cutouts, and just these limited contact points. But there was lots of problem with plate. It never really became available in mainstream use. So this is just to show you that the area underneath the plate, which is so-called footprint, where it affects the blood supply by the bone. So the limited contact DCP didn't have locking holes, and the plates many people nowadays refer to LC-DCP or DCPs is actually LCP, so locking compression plates, which is the latest generation, where it has the benefits of the cutouts underneath the plate to limit the contact with the bone, and it has a combi hole with a locking and a non-lock option, so you can apply it in different modes. As you can see on the right, here's a LC-DCP used as a bridge plate with non-lock screws. So the combination holes, as I said, the same plate can be used for different functions. We all know basically that conventional screws, compression screws, the stability is created by friction between the bone plate interface, because the screw head compresses the plate onto the bone, versus locking screws where the increased pull-out strength is achieved by the fact that the plate and the screw is angular stable. So for this to cut out, you basically need the screw to cut out through all this bone and not just pull out. Okay, so for compression plating, there's three ways how we can achieve compression using a plate. We can use the dynamic compression principle, and that's using the eccentric holes in the plate. Plate overbending, we can achieve compression at the far cortex. One can also use a tension device. Now, this is not something that's standard on sets anymore. We occasionally use it with non-unions, but you might see it on some of the sets. This will provide absolute stability, and we aim for direct bone healing with no callus formation. Important that we apply it right, so screws away from the fracture and compress the bone towards the fracture from both sides. So this is an example of a transverse fracture where you cannot use an interfragmentary screw because of the orientation of the fracture, and then using the compression plate to achieve compression. This is an example of a compression device. This was really that was used before dynamic compression plates, but some sets still have it on, so you can use it to achieve extra compression. You can also use it to, for those of them, the AO principles course, also sometimes that you can help to aid reduction. And sometimes non-union cases where you want to achieve as much compression as possible, this is a useful tool to use. Okay, so this demonstrates an important concept where you use a plate to achieve compression in an oblique fracture. So if the plate is over the apex, you can lag through the plate. Here they've used a compression tool, but it's important that you first fix the plate to the side of the bone over the apex so that you create this axilla in the bone. Then you can use the compression device, or you can use a compression screw in the dynamic hole, the opposite side of the fracture. This will compress the apex of the fracture into this axilla and achieve good interfragmentary compression, and then you can still lag in the far cortex with an interfragmentary screw through the plate. So all the ways how you can achieve interfragmentary compression, lagging through a plate achieves the highest degree of interfragmentary compression. Unfortunately, it's not often that a fracture is amenable to lagging through a plate, because you have to put the plate over the apex of the fracture. So if you think of fractures where we often use interfragmentary compression, like a fibula fracture, usually you're going to do it from a lateral approach, and your plate is going to sit on the lateral surface. So you cannot lag through the plate if the plate's not over the apex. So common places where you can lag through a plate is if you do posterior plating of a fibula, where there's the normal oblique orientation of the fracture, or sometimes in forearm fractures, depending on the configuration. Protection plate is a sort of in the AO world, that is neutralization is an old term. We moved towards using the term protection plate, but these two are really interchangeable, and both are correct to use. So this is where we reduce a fracture with an interfragmentary lag screw and then protect it. So this picture is actually not right. This is a picture of lagging through a plate. Of course, for protection plate, the interfragmentary compression is achieved first, and then the fragmentary screw gives the interfragmentary compression, but that fracture is still unstable, specifically in bending and rotation, and the protection plate protects the interfragmentary screw in bending and rotation. This is an example of a protection plate, so interfragmentary screws across the two fractures, the butterfly fragment, and then using the plate as a protection plate. Okay, buttress plate and the anti-glide plate. Now, these terms are used interchangeably in the literature, although they're not exactly the same. A buttress plate resists a shear force by applying so it resists displacement by applying a force at 90 degrees to the force applied. So if you think of this, a buttress plate would push that direction to prevent displacement. So 90 degrees to the force applied. Anti-glide plate, on the other hand, prevents displacement in the direction of which the force is applied. So in other words, an anti-glide plate would simply key in this corner to prevent displacement in this direction. That's an anti-glide plate. A buttress plate resists displacement and an angle of perpendicular to the force applied. So this, if you think of a plateau fracture, distal radius fracture, buttress plate applies a force in that direction. Sometimes the plate can be both, as I'll show you now. So the Shanska lateral plateau fracture, lateral fixation often is a buttress and anti-glide. So it's an anti-glide by keying that corner, and a buttress by applying a force in that direction. So that's an anti-glide, and then the buttress from the sides. Another example of a buttress plate here, you can see the apex is keyed in. So this is purely a buttress function, and here we basically have a mainly an anti-glide function of the plate as in the fibula. Tension band plating, not something we use so commonly. Prerequisites for that is that it needs to be on a curved bone that's eccentrically loaded, and the plate needs to be on the convex side of the bone. So probably if you think of the commonest place we use a buttress place is in a proximal femur fractures. If you do a DHS or a proximal femur plate, it basically can act as a tension band plate. Okay, let me just see what the slides are going forward. Okay, and you cannot achieve tension band plate if the plate is on the cavity of the fracture, and also if there's not a medial defect. So there needs to be cortical contact on the opposite side. Otherwise, it won't achieve compression through loading. Bridge plating for multifragmentary fractures, and our aim here is to restore length, rotation, and angulation, and not to achieve anatomical reduction. So if we aim for bridge plating, we want to stay away, we want to disturb the fracture zone as little as possible. So this is another, how can I say, common mistake that we see in orthopedic, in trauma cases. So we aim to provide relative stability and achieve indirect bone healing. So on this picture, they have locking screws in this plate, but another misconception is that you need to use locking screws for a bridge plate. You can definitely do a bridge plate with non-lock screws, and in a case like this, I definitely would not use lock screws closest to the fracture. So, sort of some tips for bridge plating: you need to have an adequate working length. You need to spread your fixation. For those who've done the AO Principles course, you remember that from the skills lab, which shows you how the working length affect the movement of the plate. So in other words, the movement in this plate will be spread across the part of the plate between the closest screws to the fracture. So all the movement in the plate here will be concentrated in this small area, and it will possibly lead to failure. If you use non-lock screws closer to the fracture, because it allows movement between the screw head and the plate a little bit, it has less of an effect on the working length. And importantly, you don't want any screws in the fracture area. So if you look here, this is a bridge plate on the tension side of a femur, heals through callus formation. So locking plates, again, can be used like a regular plate to perform the same function. So this is just using an anatomical pre-contoured plate because it fits nicely. Doesn't mean that you have to put locking screws for all the holes. So a locking plate can be used as an internal fixator without compression onto the periosteum. It has a biomechanical advantage because it has a higher force to failure, so it has a higher pull-out strength. And when locking screws first came out, it led to everyone just fixing fractures with using locking screws in all the holes, and it basically led to an increase in complication of non-union plate breakage. So I want to say you should have very specific indication. Every time you use a lock screw, you must have in your mind a clear reason why you did it. So I would say the best indication for locking lock screws is where you have a short epiphyseal segment, like you can see here in the distal femur fixation. So you have a small arterial or epiphyseal segment, and you can use lock screws to increase your pull-out strength from that area. And then in the same plate on the diaphyseal side, there's no need to put lock screws. This will have a less of an effect on your working length if you use non-lock screws. So relative indications is osteoporotic bone in elderly patient or in unions where you want to make it very stable. Put repo here in brackets because again, you're doing a plate minimally invasive. You need to use a locking screw, but in certain cases, especially if the plate is not completely reduced against the bone, you might use lock screws. So in general, tips for locking, as I like to say, think before you lock. Important that you cannot use a locking screw for reduction. So in other words, if you use lock screws, the reduction must be achieved prior to insertion of your locked screws, because once your lock screws are once you've applied your lock screws, then you can't reduce the fracture anymore. Reduce before locking, and you can never use a locking screw as a lag screw. That's a non-union machine. It just splints the fracture out to length. You can maintain compression produced by other means. In other words, if you've compressed using dynamic holes or an interfragmentary screw, you can use locking screws afterwards. So the same plate, if you look at a plate, it's sometimes the same plate can be rightly or wrongly applied, just depending on the order of the screws that were placed. And in general, osteoporotic bone, relative stability is preferred with no lag screws. As you can see here, that fracture that we just showed goes on to lots of callus formation on the opposite side of the place, and beautiful healing. So plate is a reduction tool. We can use a plate to help with fracture reduction and less invasive techniques. It depends on the area where you do it. So you can use the plate as a reduction tool in diaphyseal fractures by using a clamp to reduce the plate to the bone, or with buttress plates, you can help reduce the fragment by tightening the screws to the shaft to reduce the fragment before you put screws in the fragment. But it only works with normal screws. As you can see here, posterior plating of a sort of fracture subluxation of the knee, you can use the plate here to insert the plate in the back of the tibia, insert the diaphyseal screws first, push the fragment back into place. So to get back to our patient here, again, just to show the pre-ops and the post-ops, and before I go on to show what happened, who wants to have a go and tell me what do they think the outcome of this fracture fixation would be and why? Anyone? Otherwise, I'll nominate someone.
I can have a go.
Skulk.
Skulk, yes.
Okay, so tell us what you think of this post-operative fixation, and then what do you think the outcome is going to be?
Okay, so I think they used a LCDC plate, and I think the initial plan was likely to convert the more complex fracture pattern into a simpler one. I see there's a lag screw, and then possibly to compress it and to have absolute stability with compression and aim for primary union. Unfortunately, I don't think it was achieved. It looks like possibly the lag screw is lagging that butterfly fragment onto the distal segment, but it was fixed with a poor reduction. There was no anatomical reduction, and certainly there's still a fracture gap visible, so there was no compression. It's hard to say whether they attempted some compression with the screws, but regardless, I think it's essentially now fixed in a bridging mode with too much stability and a screw in the fracture.
Too much stability, or what do you think is the problem here? Too much stability?
Or too much rigidity, shall I say. I think your strain is likely going to be too low. Well, actually, no, sorry, it's going to be high because it's a simple fracture pattern. There's no
yeah,
sorry.
Just a few comments on what you said. So firstly, what plate is this? you said an LCDCP. LCDCP doesn't have combi holes, so it's basically LCDCP just is a DCP with cutouts underneath and doesn't have the option of locking screws. So you can see here from the combi hole, this is an LCP. And then I think this fixation, the best way to describe it is sort of the worst of both worlds. So basically, if you want, there's no clear plan here. So if you want to bridge plate this, there shouldn't be any screws in the fracture zone, okay? Because basically what they've done now, they've, instead of this, the movement will be distributed between there and there and there in the fracture zone, they've made the gap smaller, okay? The gap is the denominator that you divide by, so the smaller the gap, the more higher the strain. So if they wanted to lag this, make it two separate fragments, then you need to anatomically reduce it and take compression. Otherwise, there shouldn't be a lag screw there. Does everyone understand that?
Yes, Prof.
Okay, great. So predictably, this is what happens at 3 months. Okay, so non-union, and then of course, you know, eventually the plate will fail. Okay, so what did we do then? Afterwards, was anyone wants to comment on this post-op X-ray? Baku, what do you think?
Prof, I see a AP and a lateral of the shaft of the humerus, as we've seen from the previous X-ray, it's a revision. What I can appreciate is that one, we've used a longer plate, spanning the fracture site. We've achieved anatomical reduction, which is the second thing I see. And using the principles that we've used, interfrag screws through the plate to achieve anatomical reduction. I think giving us the plan of primary bone union, with also increasing our length of the plate. I'm assuming, considering the previous plate being a bit shorter.
If you look at how this failed, you remember the workstation from the AO course? You know, the longer the distance from here where the force is applied to the furthest screw, the bigger this force needs to be to pull it out, okay? So in general, another common mistake when you do a plating, when you do a bridge plating, remember with protection plating, the length of the plate is less important. But with bridge plating, if you're undecided between two plate lengths, always take the longer one, okay? A plate, I've never seen a plate that's too long, okay? So basically just take the longer plate. So in non-unions, we aim for as much for, for rigid fixation and interfragmentary compression for union. So this is, we've made an oblique surface. We've lagged through the plate, first achieve compression with the plate, then lag through the plate, and then long plate, and then all the other last screws to sit as locking screws, but that's after the compression to make it as stable as possible. And then it went on to healing. So I say it's important to just do it right the first time. If you look, simple biomechanical mistakes can lead to failure. So from the plating bit here, the important thing is to remember that to separate the function of the plate with the design, and the same plate can achieve absolute or relative stability, very specific indications for lock screws, and you can also use a plate as a reduction. Before we go on to nailing, any questions about plating, the biomechanics of plating?
Prof, good evening, Prof. Can I just ask a question about the previous case?
Yes, absolutely.
If that posterior, the revision X-rays, is this what plan would be the first time straight away, or did anything change because the patient had an initial surgery?
No, it's super non-union. If I had to treat this the first time, I would have think, if you have a simple butterfly, you can lag it on both sides and then do a protection plate. if I had to treat this, I would have probably just bridge plated, that I'm not going to disturb that at all, and just bridge plated. I would have looked into if we did if I could lag this to the one side and then have a simple fracture, then I would definitely compress it, but then it needs to be anatomically reduced and plated. So if it's this initial fracture, it could definitely be treated with a bridge plate or with a compression plate. It's first prize, like upper limb, usually to get anatomical reduction and rigid fixation. But if it's not possible, then you need to bridge plate it, and then you don't need that screw here. So I would have opened this and a look if I could lag in this butterfly both sides, or lag in one side, anatomically reduce and press on the other side. I would have done that. If not, you don't want to disturb the fracture zone and you just want to bridge plate it. But then I would have used a very long plate, and I would put screws not too close to the fracture on either side. Like I said, this is just mixing up the
principles. Okay, thanks, Prof.
Okay, so nailing, so biomechanics of nailing. So, I mean, basically, if we talk about nailing nowadays, we talk about fourth generation nailing. First generation nailing was just intermodality nailing. Second generation nailing allowed interlocking. And the fourth generation nails have really allowed us to expand the indications of nailing into the metaphysis of a bone, and with specific design features to allow that. And these include multiple locking screws and different angles, things like dynamic compression, locking holes that are threaded, and it allows us to expand nailing into the metaphysis. Now, the problem with metaphyseal nailing is that if you just use the diaphyseal nailing, specifically in the femur, you can just insert the nail and the nail reduce the fracture. But in metaphyseal fractures, a nail allows you to nail the fracture, but it does not reduce the fracture for you. So you, in general, need to reduce the fracture before you nail, or use specific reduction technique to nail the fracture. One of the techniques we use is the use of blocking or follow screws, as they show in this example. And the key for nailing a metaphyseal fracture is that you need to reduce it before you nail it. Okay, so blocking screws is an example of the blocking screw jig that you can use with the meta-nail from Smith & Nephew. Now, with infrapatellar nailing, this was a big issue. Nailing a proximal tibial fracture with an infrapatellar nail was very, very difficult to get it right. You often had an apex anterior deformity. So almost routinely, if you look at this an example, I'll show you an example now, use this screen to basically make a canal in the proximal tibia by using blocking screws to guide the nail down the middle of the metaphyseal segment. And once you reduce that to the shaft, the fracture was reduced. And nowadays, suprapatellar nailing for proximal fractures, you a lot less often need blocking screws, because in extension you can usually reduce the fracture. But just an example, so you can say here suprapatellar entry, and this is like a short finger that the blocking screw jig attaches to. You can see even before we cross the fracture, just a short fragment down, using the jig to put a blocking screw. I always like to think of it, I want to put a blocking screw where I don't want the nail to go. So in a fracture like this, where the obliquity is like this, the nail tends to escape on the side that is closest to the entry point. So the nail is want to take a shortcut there to prevent it from going there. I'm going to put a blocking screw or blocking wire initially, as you can see here. Now the guide wire is going straight down. And if I just push the nail, it will reduce this fracture perfectly. But now in the lateral, you might have the same problem. So this is now nail in, and this is the position in the lateral on the left, which is not acceptable. So you see that screw there is not a locking screw, that's the blocking screw. So nail out again, and then general as a tip, specifically in the sagittal plane, I don't use screws. Don't use a drill bit. The drill bit is made of a brittle metal that easily breaks. Use the entry wire. So this is the threaded entry wire, and you can see there with redirecting this the bone, the distal segment, it improves the position, but it's still not right. So here, using another one in the proximal segment to redirect the nail, better reduction, and then can insert the nail into a metaphyseal fracture with a good alignment. And there's the post-op X-ray. This is another sort of triple segmented fracture with a separate tuberosity avulsion that again you can nail, fixing the tuberosity first, and using blocking wires into an acceptable alignment. Same with distal fractures, and all the features of the 4th generation nails allow us to expand nailing into the distal tibia. So as a general principle in the lower limb, we nail what we can. And if you look at the tibia, yes, there's other techniques like plating that you can do for this fracture. If you look at the literature, the evidence would show you that you can achieve similar outcomes, but with nailing there's fewer complications, and the patient is in general quicker to weight bearing. And in general, in orthopedics, I don't like to be punished when I do everything right. So if you think of the complications of plating a distal tibia, sometimes you do everything right. You wait for the soft tissue to settle. You think of the soft tissue with your approaches, and you still get an infection problem. Where with nailing, the complications is usually related to poor technique. So in other words, the complications of nailing the distal third of the tibia is mostly related to bad surgery. So if you do everything right with nailing, in general, you get a good outcome. Where with plating, especially in the distal tibia, you're sometimes punished even if you do everything right, which I don't like. So compression nailing, this is another. Initially it was only the Smith and Nephew nailing set, but all the major nailing systems now allow for dynamic compression of the fracture. I use this almost in all non-union cases that I nail, but it's also nice in transverse or short oblique acute fractures. This is just an example of how the Smith and Nephew system works. The Smith and Nephew, you lock distal first, you lock proximally in the dynamic slot, and then you insert this dynamic compression tool into the back of the nail. The striker nail has a screw in the back of the nail, the same with Synthi, so it's slightly different, but all of them have a similar technique. This is a non-union that you can see here. So, this is actually a post-frame refracture. So you can see a transverse fracture that we treat with a nail. So you can just imagine how for strain we want to make this as rigid as possible. So we insert the nail across the non-union site. You can see the picture on the left, that's with the nail in. There's a gap of a few millimeters, but now we lock distally first. This is just an elegant or more controlled way of doing backslapping. And then you lock proximally the dynamic slot, and the compression screw, push on the screw in the dynamic slot and pull the nail back and reduce that fracture so you can't see it. And then you do the other locking, and there's the post-op X-ray. Like I said, reduce before nailing. There's also different techniques, specifically in the proximal femur. Clamp assisted reduction is an important technique. You should not start a metaphyseal nail if the fracture is not reduced. This is just an example to show a proximal metaphyseal fracture. So reduced by just pushing on it and putting a cable around it, mainly because the clamp is in the way, of your proximal locking screw, and then inserting a Kevlar-medullary nail. So again, the take-home messages is the 4th generation nails have allowed us to expand nailing into the metaphysis, but very important for metaphyseal nailing is that you need to reduce the fracture before you nail it, and you need to have multiple tricks up your sleeve in order to achieve that. As I always say, basically, the system that you use, whichever company you decide, you need to know every single feature of that nailing system top of your head, because there's a lot of features that allow you to address the complex issues. Any questions about the nailing bit? Okay, then lastly, we're going to chat about the biomechanics of external fixators. So firstly, to mention monolateral external fixators, which in my opinion should only be used for temporary temporary spanning of fractures. So a lot of this you guys already know, but with a monolateral fixator, we can cantilever loading, and cantilever loading is not good. And what cantilever loading basically means is, the best example is this diving board, because the diving board is fixed to a single point on the one side. So any axial movement would result on some deviation because the beam is at a fixed distance. Okay, so in other words, loading this will in effect create some movement away from the midline, which is basically a shear force, and we know that is something that fractures don't like. So you can use all this sort of different principles of external fixator by making it more stable, more pins, more rods closer to the bone, biplanar, but in general, it's very difficult to make a monolateral fixator stable enough, and importantly, can be too stable and still not allowed when we aim for beam load. So if you're going to use a monolateral fixator for definitive management, there are systems like the old Pro Colors from Orthofix that you see here that you can use, that has a specific biomechanical design to minimize the cantilever effect. It can't take it away completely. Now, we used to use this a lot because for open fractures, but we've become much more aggressive with nailing open fractures. And for this to work, you really need a simple fracture where there's some cortical contact. So in other words, we talk about a load-sharing fracture pattern. In a load-sharing fracture pattern, you can use a monolateral fixator because that cantilever force will be counteracted by some cortical action, a cortical contact. So in other words, here, the axial motion won't result in deviation from the midline because the cortex is in contact. Unfortunately, most simple fractures have simple wounds, and we nail all these fractures. So basically, the odd fracture that could be treated possibly with a monolateral fixator is definitively nowadays we nail all of them. But still, never say never in orthopedics, but in general, I would say no monolateral fixators for definitive management. So circular fixators have the biomechanical advantage that it eliminates the so-called parasitic movement away from the midline, only allow axial micromotion in the right plane. Now, a circular frame is not a magic wand. So basically, the fact that there's a ring around the leg doesn't mean that it has the optimal mechanics for healing. If you put a circular fixator like an Elizarov and you put all half pins in the same plane, that still acts like a monolateral fixator. So still with a circular frame, you need to apply it in the right way. But especially with tension wires or with half pins at 90-degree angles, with a circular frame, you can achieve what we call beam loading. And now here you can see, because the beam is fixed on both sides with an axial force apply, it only allows micromotion in the axial plane, and it doesn't give cantilever loading. And this is why this is biologically so much more sound compared to monolateral external fixators. So there's two types of circular frames in general: the Elizarov type, where you general have an intra-op reduction of the fracture, and then a hexapod. Now, hexapods was designed for deformity correction, and initially people just adopted that for all trauma fracture. Hexapod doesn't have great biomechanics for diaphyseal fractures. So again, you shouldn't use hexapods for diaphyseal fractures, or should have a very clear indication, like for gradual reduction in a chronic fracture, or for fracture for deformity assisted closure. In general, for diaphyseal complex fractures, you want to apply Lizeroff frames. Hexapods are fine for metaphyseal fractures. Their healing is not a problem, and it helps you to be able to fine-tune the alignment afterwards. But if you just put hexapod for mid-shaft tibias, you can have a very high non-union rate. So just an example how just manipulating the biomechanics can achieve union. This is a patient that was referred to me with 4 months after grade 3B open tibia. You can see here with a monolateral fixator with 2 bars, a fracture with a butterfly segment. The wounds were all healed. And I said this is a non-union machine. So all we did was addressing the biomechanics. So without opening the fracture, without any bone graft, we did a fibular osteotomy to optimize the mechanics of all the force going to the tibia, and applied an Lizeroff frame to just allow axial movement. We call this mechanobiologic, so we address the biological fractures just through mechanics. And 4 months later, just with the optimal biomechanical environment, the fracture healed without any bone graft or without any biological stimulation. Another nice example of how to manipulate mechanics using external fixator is this hypertrophic non-union. And this only works for stiff hypertrophic non-union, so mid-shaft, very stiff hypertrophic non-union with a deformity. So without opening the fracture, we apply, these are often so stiff that you cannot sort of elicit movement, just by manipulating the leg. Very stable frame, close distraction. So we correct the alignment and add a few millimeters of distraction, as you can see through this cap, and then that fibrous tissue convert to bone. To think about how strain is calculated is how can you make this fracture as stiff as possible if you go back here? Well, you can decrease the strain by decreasing the amount of movement, right? Okay, so applying a stable frame will make the movement less, so the strain lower. And then how will the gap influence strain? Well, by making the gap bigger, you will have even a bigger influence on the strain than making it smaller. So basically, when someone first told me that you must distract a non-union to make it more stable, I thought they're mad. But if you carefully think about how strain is calculated, it does make sense. And then this is to union without the fracture site at all. So the take-home message again is the biomechanical features of the monolateral and circular external fixators, the concept of cantilever and beam loading, and how you can increase stability with external fixation. Thank you very much.